My seminar is about combined surgical and orthodontic treatment. It is done by Hussein Ali Abdel Hadi. It is part 1. The outline. The outline of my lecture is indication for orthognathic surgery, development of orthognathic surgery, the borderline patient camouflage versus surgery, and finally contemporary surgical technique. Indication for orthognathic surgery is orthodontic problems are so severe that neither growth modification nor camouflage offer a solution. The question is orthognathic surgery a substitute to orthodontic treatment? The answer is there should be a coordination between orthodontic and orthognathic surgery, and always there should be a pre-surgical orthodontic treatment. This girl at age 14, she has severe anteroposterior and vertical maxillary deficiency with large mandible. The treatment was postponed for 1 year to ensure that active mandibular growth has been ended. At age 15, we started treatment by using orthodontic treatment for removal of any dental-alveolar compensation for skeletal discrepancy. The picture on the right side is at age 17 after 2 years ortho treatment to remove any dental-alveolar compensation for skeletal discrepancy. The picture on the left side is before treatment. The picture on the right side is after treatment by using first pre-surgical orthodontic treatment. Then we use orthognathic surgery by maxillary advancement and mandibular setback. This is cephalometric for the same patient before and after treatment. This is after treatment. As I said before, the treatment was done by maxillary advancement and mandibular setback. Development of orthognathic surgery. Surgery for mandibular prognathism began early in the 20th century by using body osteotomy. Removing premolar or molar and block of bone are removed. In 1957, it marked the beginning of the modern era in orthognathic surgery. Intraoral approach without skin incision is used by using sagittal split osteotomy to set back or advancement of the mandible. During 1960, a decade of rapid progress in maxillary surgery which allowed repositioning of the maxilla in all 3 planes of space by using Lefort 1 down fracture. In the 1980s, it was possible to reposition either or both jaw, move the chin and dental-alveolar segment in all 3 planes of space. In the 1990s, a rigid internal fixation greatly improved patient comfort. Around the turn of century, the introduction of facial destruction osteogenesis has large effect because large jaw movement is possible and treatment at an earlier age are also possible. The borderline patient camouflage versus surgery. Malocclusion severity is an indication for the surgery. So the malocclusion severity, mild or moderate or severe, is the factor that determines the treatment plan for the patient. Now we discuss the envelope of discrepancy. The envelope of discrepancy shows the amount of changes that could be produced by orthodontic tooth movement alone, which is the inner envelope of each diagram. So the inner envelope of each diagram, which is the yellow envelope, describe or show the amount of changes that could be produced by orthodontic tooth movement alone. The middle envelope shows the orthodontic tooth movement combined with the growth modification, while the outer envelope shows the orthodontic surgery. We notice that there is more potential to move teeth forward than backward and more potential for extrusion than intrusion. Since growth of the maxilla cannot be modified independently of the mandible, the growth modification envelope for two jaw is the same. Surgery to move the lower jaw back has more potential than surgery to advance it. The limits vary according to the direction of tooth movement and the patient age. This envelope outlines only the limits of the hard tissue, doesn't limit the envelope of the soft tissue, and it is not reflected in this envelope. Orthodontic surgery versus temporary skeletal anchorage. The question is, will temporary skeletal anchorage, or TAD, decrease the number of patients who need surgery? The answer is the limits of orthodontic treatment is concerned with facial appearance than the anchorage. So, tooth movement with orthodontic treatment for patients with jaw discrepancy is considered camouflage successful only if the jaw discrepancy is no longer apparent to be a problem. So, orthodontic treatment for patients with jaw discrepancy is successful, camouflage successful, if the patient apparent is no longer a problem for the patient. Skeletal anchorage may be alternative to orthodontic surgery. In these cases, first, moving the maxilla up with mini plates. That will correct anterior open bite by using mini plate. TAD will correct anterior open bite by using mini plate at the base of zygomatic arch. As happened in this case, we use TAD to correct anterior open bite by using mini plate at the base of zygomatic. Second, a protraction of the maxilla in pre-adolescent children. In this case, TAD are used with the class 3 elastic between posterior maxilla and anterior mandible. It is effective treatment for protraction of the maxilla. Patient and parents should understand that surgical treatment still may be needed because of post-treatment growth, aesthetic and psychosocial consideration. The negative effect on psychological and social well-being is increased with the severity of dentofacial disfigurement. Improvement in the facial appearance is the major goal of our treatment. The integration of orthodontic and facial plastic surgery is current and entirely rational trend. So there is coordination between orthodontic and facial plastic surgery, and also there is a coordination between orthodontic and orthodontic treatment always. The good things that the majority of the patients who undergo orthodontic procedure report long-term satisfaction with the outcome, 80 to 90%. They would recommend such treatment to other people and would undergo it again if required. The negative psychological effect from surgical treatment. First, there should be adaptation to significant changes in the facial appearance. The patient appears with a new appearance, so there should be adaptation to these changes in the facial appearance. We should first understand the goals of each patient, younger adult or older adult. The younger adult, the goal is to improve their quality of life, whereas in the older adult, the goal is to maintain what they have. So in the older adult, we don't need to do significant changes. A period of psychological adjustment following facial surgical procedure is always required. This is maybe attributed to steroid withdrawal, because during surgical procedure, steroid may be taken. So steroid withdrawal, even after short-term use, causes mood swings and a drop in the most indicator of psychological well-being. This is a diagram which represents psychological well-being and the treatment, pre-treatment, immediate pre-surgery, 1 week, 6 weeks, and 1 year. We notice that 1 year later, the psychological well-being will be good or high after 1 year. Interestingly, orthodontic surgery doesn't rate high on the discomfort and morbidity scale. Operation involving the mandibular ramus require about the same amount of pain and require medication as extraction of impacted wisdom teeth. Maxillary procedure are tolerated better than mandibular procedure. Computer simulation of alternative treatment outcome. It is moral and ethical imperative to allow the patient to make important decisions about what treatment he or she will prefer or accept. Computer image prediction are particularly valuable, helping patients to decide between camouflage and surgery and planning surgical treatment. Also, the patient can view the impact on the soft tissue profile of orthodontic camouflage versus surgical treatment alternatives. And only the patient can decide whether the difference between surgical correction and orthodontic camouflage would be worth the additional risk and cost of surgery. This slide shows the surgical prediction for patients with skeletal class 2 problem with mild maxillary intrusion, severe mandibular deficiency, and inadequate projection of the chin. This is the initial tracing linked to the profile photograph of the same patient. This is the first treatment option, which is simulation of 5 mm of mandibular advancement. This is the second treatment option, which is 5 mm of mandibular advancement plus genoplasty to improve chin projection relative to the lower incisor. Or maybe 6 mm of maxillary advancement and 11 mm of mandibular advancement and rhinoplasty. The patient chooses the middle picture. She chooses the middle picture as a treatment plan for her problem, which is preoperative retraction of the lower incisor after lower premolar extraction, creating more overgent and allowing 9 mm mandibular advancement. This is the final treatment option, which is the retraction of lower incisor and 9 mm of advancement and rhinoplasty. The middle picture was selected as a treatment plan for that patient. Extraction of teeth and camouflage or surgery decision. The decision for camouflage or surgery must be made before treatment begins. It is a serious error to attempt camouflage on the theory that if it is failed, the patient can then be referred for surgical correction. So, from the beginning, we should decide either to go in the way of camouflage or to go in the way of orthodontic surgery. This man, who had a previous orthodontic treatment to correct his class 3 malocclusion, complained from maxillary deficiency and prominent chin on profile view. That is mean that class 3 camouflage is failure because it doesn't improve facial appearance of the patient or camouflage the skeletal problem of the patient. In this case, we need to go back to remove dental compensation by retracting maxillary incisor and proclining mandibular incisor. This is cephalometric superimposition showing the changes created by maxillary advancement surgery. So after maxillary advancement surgery, the patient profile has been improved. And before we do maxillary advancement, as I said, it is required to do pre-surgical orthodontic treatment to remove any dental-alveolar compensation and to return back to the case before camouflage has done. The critical importance of deciding on camouflage or surgery is illustrated by the difference in extraction needed with the two approaches. In case of camouflage, extraction spaces are used to produce dental compensation for the jaw discrepancy. Whereas in surgery, extraction spaces are used to remove any dental compensation for the jaw discrepancy. So the opposite occurs between the camouflage and surgery. What about patient with skeletal class 3 problem? If camouflage were planned, typical extraction might be lower first premolar alone, or lower first premolar and upper second premolar, or one of the lower incisor. Whereas if surgical preparation were planned, moving the lower incisor forward and retracting the upper incisor is advisable. This may require extraction of the upper first premolar. As general rule, class 3 problems are less amenable to camouflage than class 2 issue because retracting the lower incisor may make the chin appear even more prominent. Patients who could be treated with either orthodontic or surgery should understand all these considerations in deciding which to choose. First, orthodontic camouflage of skeletal malocclusion. The acceptable results are likely average or short facial pattern, mild anterior-posterior jaw discrepancy, crowding less than 4 to 6 mm, normal soft tissue feature, nose, lips, and chin. No transverse skeletal problem. Whereas the poor result likely long vertical facial pattern, moderate or severe anterior-posterior jaw discrepancy, crowding greater than 4 to 6 mm, with exaggerated features. And finally, transverse skeletal component of a problem. Contemporary surgical technique. The possible jaw movement with surgery is in transverse dimension. Maxilla can be expanded laterally or constricted with reasonable stability. The amount of constriction possible is less than the amount of expansion in the maxilla. So, the large red arrow indicated the amount of expansion in the maxilla, whereas a small red arrow indicated the amount of constriction in the maxilla, and the amount of expansion is larger than the amount of constriction. While in the mandible, the only transverse movement easily achieved in the mandible is constriction, and limited expansion is possible with destruction osteogenesis. So the amount of expansion in the mandible is less and only achieved by destruction osteogenesis, which is represented by a small red arrow. The maxilla, the mandible. Now we talk about the anterior movement. The maxilla and mandible can be moved anteriorly and posteriorly, and the mandible can be moved anteriorly for 10 mm, and maxilla can be moved for 6 to 8 mm. The possibility of relapse or speech alteration from nasopharyngeal incompetence increased with larger amount of anterior movement. So the limited amount of anterior movement in the mandible 10 mm, in the maxilla 6 to 8 mm. Now we talk about the posterior movement. The posterior movement of the maxilla is difficult and unnecessary, and instead we can do segmental osteotomy for the maxilla, which is removal of premolar followed by segment of the bone of the maxilla. While in the mandible, the major limitation of posterior movement of the mandible is its effect on the appearance of the throat. When the mandible is moved back, the tongue moves down as the airway is maintained, and turkey gobbler prominence appear below the chin. So the limitation in the posterior movement of the mandible is the effect on the appearance of throat, and turkey gobbler appearance appear. Now we talk about the vertical movement. First, we talk about the mandible. The mandible can be moved down to increase mandibular plane and anterior facial height, and it is okay, it's a stable result. But rotating the mandible up to decrease the mandibular plane angle and decrease anterior facial height is unstable unless the maxilla is moved up posteriorly at the same time, so that there is no stretching on the elevator muscle. Now we talked about the vertical movement of the maxilla. The maxilla can be moved up with excellent stability and moved down with difficulty because of instability. Now we talk about mandibular surgery. The sagittal split osteotomy. Advantage over other mandibular surgery. First, the mandible can be moved forward or back as desired, and the tooth-bearing segment can be rotated down anteriorly, which increases the mandibular plane angle when additional anterior facial height is desired. Second, the procedure is quite compatible with the use of rigid intraoral fixation, so immobilization of the jaw during healing is not required. Third, excellent bone-to-bone contact, which means problems with healing are minimized and post-surgical stability is good. Lower border osteotomy. A lower border osteotomy of the mandible to reposition the chin relative to the mandibular body is a major adjunctive treatment to Ramus procedure, especially when the mandible is advanced. The lower border procedure allows the chin to be moved transversely, forward or backward, up or down. Maxillary surgery. It is done by the Lefort 1 osteotomy with down fracture of the maxilla, which allows the maxilla to be moved up and or forward with excellent stability, and moving the entire maxilla back is quite difficult because of the presence of the structure behind it. But this is not necessary because of segmental osteotomy can be done instead. A segmental osteotomy is done when the upper teeth are protrusive, when there is anterior open bite with an increased facial length, allow the posterior maxilla to be widened or less frequently narrowed. This is patient before treatment. This is the patient after treatment using segmental osteotomy. Now we talk about the expansion of maxilla. Expansion is done with parasagittal osteotomies, either in two-piece osteotomy or in a three-piece osteotomy. Expansion is done with parasagittal osteotomy in the lateral floor of the nose or medial floor of the sinus that are connected by transverse cuts anteriorly. While on the two-piece osteotomy, a midline extension can run forward between the root of the central incisor. This may or may not be included in a three-piece osteotomy. The picture on the left side, which is two-piece osteotomy, we note that there is a midline extension run forward between the root of the central incisor, while the picture on the right side there is no extension. Resection of the cartilage of the nasal septum is important so that the maxilla can be moved up or down. The question is, can we use orthopedic palatal expansion of the type used in adolescent with adult? The answer is, due to increased resistance from interdigited midpalatal and lateral maxillary suture, there will be a resistance to expansion. But recent studies have shown that a small increase in maxillary width still can be achieved with palatal anchoring. Surgically assisted rapid palatal expansion using bone cuts to reduce the resistance, followed by expansion of the jack screw to separate the halves of the maxilla, is another possible treatment approach for adult patients with narrow maxilla. Relapse and stability of surgically assisted rapid palatal expansion. The dental expansion accompanies surgically assisted rapid palatal expansion, and its long-term stability is similar to that with segmental osteotomy. The only indication for preliminary surgically assisted rapid palatal expansion is severe maxillary constriction. That segmental expansion might compromise the blood supply to the segment. Now we talk about the dentoalveolar surgery. Segment of dentoalveolar process can be repositioned surgically in all three planes of space. But there is a limitation. First, the distance of the movement, which is only few millimeters. Second, the size of the segment. One tooth segment is a problem So the farther the segment is moved away and the smaller it is, the greater the chance of interrupting not only the usual blood supply but also collateral blood supply. So always we should take a large segment and for small distance. And thank you for listening.